Okay, welcome everyone. We're happy to have you guys all on today. We are going to have a
Hey, Amy.
guest speaker. I'm going to go ahead and mute that. Um, my name is Callie
Why can't we
Pickens,
hear her?
and
Oh,
I
down on the
am
bottom.
happy to have all of you guys on, and I'm happy to be partnering with the Wyoming Department of Health. And I'm going to turn it over to Tim Kozad to introduce our speaker today.
Thanks, Kelly. Yeah, so I have the privilege of introducing our speaker, Jennifer LaBay. Jennifer is a curriculum development specialist with APACN. She's been involved in the RAI process since 1997 and has been in the post-acute care arena since 1991, serving in a variety of capacities, including a CNA, charge nurse, MDS coordinator, and regional corporate clinical reimbursement specialist. Jennifer has considerable expertise in the MDS 3.0 and RAI process, the prospective payment system, and ICD-10, including the clinical and financial aspects. So with that, take it away, Jennifer.
Thank you so much, Tim, Callie, and Mary, for having me. I'm very happy to be joining you again to talk about some of the changes that are coming up effective October 1st, 2023. There are many changes. Unfortunately, we're not going to have time to talk about all of them. So we're going to do a little bit of a deeper dive in sections D, K, and O. And we are going to look at some of the overall changes in general and then do that little bit of a deep dive. I'm going to go off camera so we can focus on the slides. I'll come back on at the end when it's time for our Q&A. So let's see. All right, so we have some commonly used acronyms. As always, we do love our acronyms in our setting. So you can use these to reference. So let's go over some of the general updates throughout the manual. CMS released the draft manual in April, and they came out with the final manual last month in August. And they did a lot of general updates with website updates, version, dates, page numbers. They did change a lot of the language to gender neutral language throughout the body of the manual. And a lot of the language was updated to align across the post-acute care settings, home health, long-term care hospital, inpatient rehab, those different settings that we all have to align with for the IMPACT Act and the QRP measures. Some coding examples were modified to improve clarity. There was some clarification on some skip patterns and some instructions added in several areas. Any references to keys ASAP were changed to I keys. And there was an adoption of the phrase data elements versus items, although sometimes they're still referred to as items, sometimes they're data elements. There were also revisions made pertaining to legal proxy information for family member, significant other, and or guardian, legal authorized representative. And the language for the optional state assessment was removed. That was moved into its own manual and form, which can be found on the CMS webpage on the MDS page under downloads. So the first things that we're going to look at that are new for October 1st, 2023 are the SPADE, Standardized Patient Assessment Data Elements. This was part of the Improving Medicare Post-Acute Care Transformation Act, or IMPACT Act of 2014, which requires CMS to develop and implement and maintain the SPADES for the PAC settings. And as I said, the home health, inpatient rehab, long-term care hospitals, and SNFs, we all have to look at these things in all of our settings. So there were some updates to ethnicity and race and language, some added items with transportation, health literacy, and social isolation. And these are looking at standardized things to facilitate care coordination and interoperability and improve Medicare beneficiary outcomes. So section A, we have some updates. A1805 entered from. We have some changes to the locations of entered from and discharge status. It is strongly recommended, if you have not looked at the final manual, that you do so, because again, we are not going to have time today to go over all of these changes. The nice thing that CMS does do is all of the changes are going to be red italicized. So when you download that manual, you will see all of the changes from that current version 1.17.1 with the October 19th effective date. You can see all of those changes. Now, if you are familiar with what was in the draft manual from April, CMS did put out a nice change document showing what the changes were from the draft to the final. So that is another document that you can find, cms.gov, the MDS page at the very bottom with the downloads, where you can find the final manual and the final item sets. You can also find this change document from the draft to the final. So that is a nice thing. Some of the other things added in Section A, provision of current reconciled medication list to subsequent provider and to resident. There's also the route of that current reconciled medication list to subsequent provider and resident. Those are to meet the SNF QRP transfer of health information requirements. Section G and GG. Section G for federal purposes has been removed. So it is not going to be the usual Section G items. Some states are choosing to add things in different ways. Some states are doing optional state assessments. We're not discussing any of that today, but for the federally required assessments, Section G was removed, and Section GG added for all OBRA and PPS assessments. So Section GG is going to be completed on your quarterlies, on your admissions, on your annual SIG change, significant correction, as well as the PPS 5-day and interim payment assessment. A couple of the items that were removed from Section G have been added to Section GG, including functional limitation and range of motion, mobility devices, personal hygiene, which will be assessed on OBRA assessments only, and tub and shower transfers, also assessed on OBRA assessments only. So because we have different look back periods and use of Section GG, there are different look back periods as well, depending on the type of assessment. So although we're not going to dive deep into this, I did want to provide you with these grids to show you what those different look back periods are. So if we're doing a standalone Medicare PPS assessment, it's the first 3 days of the stay is the assessment period for Section GG, and that's starting with A2400B, that start of Medicare date. If it's a standalone OBRA admission not combined with a 5-day, it's the first 3 days of the stay starting with the entry date at A1600. And this is regardless of what your ARD is. So these are the look backs regardless of your ARD. And if you have a combined Medicare 5-day with your OBRA admission assessment, that's going to follow the PPS rules. So again, you can use these for reference. When looking at column 3, discharge performance, our assessment periods are looking back to the discharge date, A2000 plus the 2 previous calendar days. A Part A PPS discharge is A2400C, that Medicare end date and the 2 previous calendar days. And then if we have a combined OBRA and Part A PPS discharge, this is going to be the end date of the most recent Part A stay, any A2400C and the 2 previous calendar days. But we do have a little bit of a difference of what dates would be when. So this is another hopefully nice flow chart for you to reference when looking at that discharge performance for a combined OBRA and Part A PPS discharge, because it's a little complex. So the item set states when A310G is not 2 and A310H equals 1, and A2400C minus A2400B is greater than 2, and A2105 is not 0.4. So it's like, oh my goodness, what is all of this? So hopefully you can use this flow chart to guide you through. So we're starting OBRA discharge assessment, A310F equals 10 or 11, return, anticipated return, not anticipated, or that yes, this is a PPS discharge. Then we have to ask ourselves, is the discharge unplanned? Yes or no? If it's yes, the stay is going to end at A2000, and it will be A2000 in the 2 previous days will be your look back period for section GG. If it's not an unplanned discharge, then we have to look at the length of stay. Is the Medicare stay greater than 2 days? If it's not, then again, the stay ends with the discharge date A2000. If it is, then we keep asking more questions. Did the resident discharge to a short-term general hospital? If the answer is yes, then again, A2000 is going to be the end date of that look back period. And if not, then the stay and the observation period will end on the Medicare end date, which is A2400C. So it gets a little tricky. Hopefully this will help you with this. And then we have column 5, which is now OBRA interim performance. So as I said, section GG is now being completed, admission, quarterly, SIG change, all of those assessments. If we're doing this for our interim payment assessment, it's the assessment reference date of the IPA and the 2 previous calendar days. And then for that standalone OBRA assessment, which is not an admission, it's going to be the ARD in the 2 previous calendar days. So hopefully these charts will help you determine what that look back period is for section GG. Note they are all 3 days. There is not a 7-day look back period for these items in section GG. So that is a big difference. Section J, we had some data element number changes and the answer key changed. So instead of asking yes, no questions related to pain effect on sleep or pain interference with activities, it's now looking at the frequency of those items. We've also broken up the pain interference with therapy activities versus day-to-day activities. So make sure that you have a close look at those new items. Section N, N0415, high-risk drug classes, use and indication, added antiplatelet and hypoglycemics as additional drug classes. And then there was a column added for indication. So we're not indicating the number of days that the drug classes were used. It's just a checkbox. So if they received any of those high-risk drug classes, and this is based on the category, not why it's used. So if any of those were used in the 7-day look back period, you're going to check that first column. And the second column will be indication for use, which would be the identified documented clinical rationale for administering a medication that is based upon a physician's or prescriber's assessment of the resident's condition and therapeutic goals. This was added with the final release of the REI User's Manual. If there are multiple drugs in one class used, so for example, if there are multiple antidepressants used, there needs to be an indication documented in the medical record for each of those medications that are in that drug class. So if one is missing, then we can't check off indication. Section Q, there was a few changes here. Participation and assessment and goal setting broke it down. Instead of asking participation, it broke down the questions a little bit differently. We're looking at asking the resident first, very, very clear language stating that we should always be starting with the resident first, and then we could go to the family or significant other or legally authorized representative. And then we do also have a reason for referral to local contact agency not made. So we ask the question, was that referral made? If we say no, then we need to indicate the reason. So we do have some changes throughout the REI manual. And CMS has put out quite a bit of training. You can find these trainings on the YouTube channel that CMS does have. There are a couple of different sets of training. The first pre-recorded trainings were out in June, I believe, and then they did a live one in July or May and then June. We had 2 sessions, so they are out there. And the follow-up frequently asked questions document just recently came out as well. What's tricky about this training and the documentation related to this training, it's not on the MDS page. It's actually on the SNF QRP training page. So it's maybe a little bit hard to find when you're looking for it on CMS. So it's cms.gov. Do a search for SNF QRP and look to the left-hand side of the screen, look for SNF QRP training. You're going to see the links for all of these training materials, all of the documentation that goes with it, and the frequently asked questions, which should be used as a reference as well. So that puts us through our very, very brief general overview of the changes. As I said, strongly recommend downloading that final manual and reviewing those changes before October 1st, because that's coming very quickly. So let's dive into where we're going to focus today. And section D is the first section that we're going to be looking at. D0100, should the resident mood interview be conducted? So the instructions to complete this interview the day of or the day before the ARD has been removed. There was some questions asked of CMS about when should we be completing this interview, anytime in the 14 days, or is this a 7-day look back? The 14 days is just the time frame for the resident to answer the questions about the mood. The look back period for asking the questions is actually 7 days. So we need to be asking these questions during the 7-day look back period, but still asking in the past 14 days, have they exhibited any of these items? So that's a change that we need to be mindful of. There was also clarification that is, if an interpreter was wanted or needed but not available, the gateway question would be answered no, and the staff assessment would be completed. So we are seeing some added language that was in the draft. They just recently came out with an errata that removed this information, which really limited when we would be going to the staff assessment. And we had some questions about that. And in reaching out to CMS, I heard back today that they did not realize there was some contradictory language between the errata that was just released and page D13 of the REI User's Manual, which basically says if the resident's unwilling or unable to participate in the mood interview, that we should do the staff assessment, but the language in the errata says that we should not. So they need to bring that back, and hopefully we will hear some clarification before October 1st. But in the meantime, let's talk about what CMS is really pushing for, and that is hearing the resident's voice. So this is no longer a PHQ 9 interview. It is now PHQ 2 to 9. And we're going to start with the first 2 questions of the PHQ interview to determine if we are going to go further with the remaining 7. So item D0150, again, this is very similar to how we've been doing it over the last 2 weeks. Have you been bothered by any of the following problems? If the symptom is present, we're going to enter yes in column 1, and then we're going to ask the resident about frequency in column 2. How we answer, or how the resident answers in A, D0150A or D0150B, is going to determine whether we're going to go on to the remaining 7 questions. So if D0150A1 and D0150B1 are coded 9, meaning there's no response, column 2 would be left blank. And then you're going to end the PHQ2 right there and leave D0160 total severity score blank. You are not going to move on to the staff assessment. You are going to move on to the staff assessment at that point. If you do both D0150A2 and D0150B2 are coded 0 or 1, so symptom frequency, for these questions are coded 0-1, meaning either the resident said that no, they did not have these symptoms, or yes, they did, but it was never or 1 day or 2 to 6 days in both A and B. Then you're going to end the PHQ-2, enter the total score from the for D150A2 and D150B2 and D160, the total severity score, and you're going to stop there. So if the resident did not answer the first two, you can go to the staff assessment. If the resident answered, but their answers were a 0 or 1, you're done. We can't move on. We can't go to the staff assessment. We can't ask the remaining 7 questions. If there is any other combination or scenario other than those first 2 boxes, then you're going to proceed to the remaining 7 questions. So one of the items that we asked, well, what if one of the questions is 9, no response, and the other question is no? What do we do then? And that falls into that 3rd box there for all other scenarios. Proceed to ask the remaining 7 questions. So this gets a little tricky because this is going to impact what we are capturing for PDPM. So we may not get enough information to score PDPM with that depression end split. So it's very important to understand these coding scenarios. So again, if both of these items are coded 9, you're going to leave the total severity score blank, and you can proceed to the staff assessment. So that means we would be able to fully assess the resident's mood through the staff assessment and potentially appropriately get those depression end splits for PDPM payment. And then we have the other scenario. If they're coded 0 or 1 in column 2, we can't go any further. We code the total severity score. In D0160, we stop. We don't ask the remaining 7 questions. We don't go to the staff assessment, and we don't have any assessment of our depression end split. So very important to make sure that we are utilizing all of our techniques for interview to make sure that we are truly asking these questions in a way that is going to elicit a true response, and that we're not just going through the motions and asking the questions quickly and taking the answer at face value. We're not trying to change anything or game the system or encourage the resident to answer a certain way, but we want to make sure that we are utilizing those techniques in a way that we are truly getting that resident's voice. So I do have another couple of grids here, hopefully to help you understand for reference, what do we code, where do we code it, what does it mean? So you can use this guidance as an additional reference, which basically says the same thing that we just went over, just in a quicker way to see that. So for all those other scenarios that did not meet both of them being coded 9, or both of the column 2 being coded as 0 or 1, we can complete the full PHQ-9. So as I said, that's going to possibly impact the depression end split for the nursing component for PDPM due to that decreased opportunity to complete the full PHQ-9. So to get that depression end split, the PHQ-9 score would need to be 10 or higher. And if we can't get the full 9 questions asked, we're not going to get an end split of 10 or higher. So as I said, you want to utilize those interview techniques that are in Appendix D of the REI User's Manual to ensure full assessment of those responses. Disentangling and unfolding are the 2 techniques you really want to focus on. So for example, disentangling is when we're kind of breaking things down. You'll notice the first 2 questions have multiple parts. So over the last 2 weeks, have you been bothered by little interest in doing things or little pleasure in doing things? If you break that down into 2 separate questions and allow the resident time to answer, some residents may have a difficult time answering and may take up to 30 seconds to answer. So we need to allow them that time, ask the questions disentangled, so we can get the full resident's voice as to have they been bothered by little interest in doing things or little pleasure in doing things. And then whatever that highest frequency is, that's what you would code for D0150A. Same thing with D0150B. That has 3 different items. You can break that into 3 separate questions, give the resident time to answer, and then whatever the highest frequency is, that's what you're going to capture on the MDS. Unfolding is another technique because the symptom frequency may be overwhelming for the resident. Even if you're using a cue card, we've got number of days, we've got verbal descriptor, and providing too many choices for symptom frequency may be too much. So instead of offering all of it, let's kind of break it down. Either we're going to ask the number of days, or we're going to ask the verbal descriptor. Start from there. Don't show them everything because maybe they're not going to grasp that. Then once you determine whether you're going to do number of days or verbal descriptor, then ask, well, is it less than half of the days? And then you just assess either that 0 to 1 or 2 to 6, or if you're using the verbal descriptor, never or 1 day or several days. And if they, or would you say it's more than half the days, and then you can just give them that breakdown. Allow them time to look at these different items more slowly so they can grasp that. So either the verbal or the numeral, and then less than half a day is more than half the days, kind of breaking it up for them to elicit a response, hopefully. Findings suggesting mood distress could lead to identifying causes and contributing factors for symptoms and identifying interventions, treatment, personal support, environmental modification. So it's not just obviously PDPM. We're not just worried about that. We want to make sure that we're assessing the resident. Now, certainly we can do the full PHQ-9 outside of MDS completion. If you wanted to do that PHQ-9 as part of your medical record to get the full picture, you certainly can do that, but it's not going to be coded on the MDS. We have to follow what the coding instructions are for the MDS. Responses can indicate possible depression if the full PHQ-9 is completed and 5 or more of the 9 items occurring half or more of the days can indicate major depression. Now, none of these items are going to identify a diagnosis. We're going to bring this information to the physician or physician extender and give them that information. And this is just a guide really for the physician or physician extender as to what this would be suggested to be. If D0150A, feeling down, depressed, or hopeless, or D0150B, trouble falling or staying asleep or sleeping too much, feeling tired, having little energy, are identified as a frequency of half or more of the days. This could also be an indicator of minor depression, but again, we would just have to give this information to the physician. As has always been, the signs of depression and the PHQ score can be tracked over time. Now, this is going to be a little different because we're going to be going from one assessment that has the full PHQ-9 assessment to the tracking of just a PHQ-2. So we're probably going to see a lot of improvement, but it may not necessarily reflect a true improvement just because we're looking at 2 questions instead of the full 9 questions. So that's something to consider when comparing between a pre-October 1st ARD and a post-October 1st ARD for the total severity score. Some additional Section D updates. This is one of those social determinants of health, social isolation, staff assessment of resident mood is, before we get to the social isolation, the 14-day look back was removed. As I said, it's just a 7-day look back, and then conducting the interviews during the 7-day look back period, as I mentioned. Social isolation is one of those spades. So this is a new item, D700, social isolation. And although this is not a scripted resident interview, this is a resident voice interview. So we have to start with the resident. And what we're looking at is social isolation, which refers to an actual or perceived lack of contact with other people, such as living alone or residing in a remote area. So we are going to ask the resident. We have to start with the resident first. We can't go anywhere else. No other resources can be used to identify the response, even if the resident is unable to respond. So how often do you feel lonely or isolated from those around you? Never, rarely, sometimes, often, always. Resident declines to respond or resident unable to respond. We cannot ask anyone else, and we have to go by whatever the resident says. Even if they're getting visitors every day, everything looks hunky-dory, and we ask them the question, they say always, that's what we have to code on the MDS. The care plan, the medical record, the assessment, that's going to include everything, but the MDS has to follow what the resident says. As I said, no other sources can be used to assess this. So those are our big changes in section D. So now let's look at section K. So K520 has had a number change. The data element is numbered differently than it currently is. And we have some additional columns. We have on admission and at discharge were added, and while a resident and while not a resident are numbered differently. So this is looking at on admission only for a PPS 5-day assessment, looking at days 1 through 3 of the SNF PPS stay, starting with A2400B. If this is not a PPS 5-day assessment, on admission is going to be skipped. At discharge, column 4, this again only completed on a PPS stay for a PPS discharge assessment. This is the last 3 days of the SNF PPS stay, ending on A2400C. So if this is not a PPS discharge assessment, column 4 will be skipped. And then we have the while not a resident. While a resident, that is going to be a 7-day look back. While not a resident would only be if your admission assessment was day 5. We've got 2 days that the resident was not in the facility. While not a resident would be anything that happens prior to the date at A1600. And then while a resident is going to be any of these nutritional approaches that happen while the resident is in your facility in that 7-day look back period. It's important to note that with the addition of the on admission and at discharge columns, this does not have any impact on PDPM calculation. PDPM calculation is still coming from the while not a resident and while a resident columns. So if you have somebody with parenteral IV feeding, that calculates the special care high nursing component from column 2 and column 3. So important to keep in mind. And again, I've got a nice grid here for you for a quick reference as to what the different columns look back periods are and what are they used for. So column 1 on admission, we talked about that first 3 days of the Medicare stay. And this is a SPADE for SNF QRP. So if you do not complete this and dash this item, that will count against your reporting threshold for the SNF QRP program. This is not, a course on that. So if you have questions on SNF QRP, you can reach out to me, go to the SNF QRP page on CMS to get more information from that. Column 2, column 3, while not a resident, while a resident, as I mentioned, those look back periods. So these 2 items are used for PDPM reimbursement, and then column 4 also used for SNF QRP spades. So this is another quick reference for you for those look back periods, because it can get a little tricky now that we have these additional columns. K520B feeding tube has a new coding tip. Only feeding tubes that are used to deliver nutritive substances and or hydration during the assessment period are counted here. So if they just have a tube in place and it's just being flushed for patency, that does not count. It's only if they are getting nutrition or hydration through the tube do we capture it on the MDS. Mechanically altered diet, we have a new coding tip, and this was something that was mentioned last year at some point. A question was asked if a resident has a trial of a mechanically altered diet. So let's say they're on a ground diet or they're on a tube feed and speech therapy is working with them and they're trying the puree or they're trying thickened liquids. If they're just doing trials with speech therapy, that does not count as a mechanically altered diet. Once we have a new diet order in place from the physician or physician extender for that mechanically altered diet, only then can we code it in K0520C. We also have an updated definition for therapeutic diet. There's a clarification. A therapeutic diet is a diet intervention prescribed by a physician or other authorized non-physician practitioner that provides food or nutrients via oral, enteral, and parenteral routes as part of treatment of disease or clinical condition to modify, eliminate, decrease, or increase identified micro and macronutrients. So this was an updated definition in the REI User's Manual. And that brings us to Section O. We've got a lot of updates in Section O. Let me just take a quick sip of tea here because I'm going to be talking for a bit. Okay, O0100 has been updated. It is now O0110, Special Treatments, Procedures, and Programs. We have some new columns and one column was removed. So on admission and at discharge were added. And while not a resident was removed, the admission and discharge columns are only completed with a SNF PPS stay. And once again, PDPM calculation is still coming from the while a resident, which is now column B in O0110 starting October 1st. So on admission, first 3 days of the stay starting with A2400B. While a resident, we have a 14-day look back here. So this is performed while a resident of this facility within the last 14 days. And then at discharge, the last 3 days of the Medicare stay. So if this is not a Medicare assessment, you are only going to be completing column B while a resident. So once again, we've got another grid here for you to help break down the difference and what things are used for. Column 1 is again spades for SNF QRP, and the dash will count against that reporting threshold. Excuse me, column A, not column 1. Column B, while a resident, this is used for PDPM reimbursement, and column C at discharge, once again, is one of those spades for SNF QRP, and the dash will count against reporting threshold. So we need to make sure that we have documentation to support these items. So let's take a look at each of the different items. O0110 cancer treatment. We've got a lot of subcategories added here. So chemotherapy, the definition has not changed, but what we're looking at under the subcategory for the SNF PPS stay only. So on admission at discharge, we need to determine if the chemotherapy was administered on admission in the first 3 days of the stay via IV, oral, or other route of transmission. And again, looking at that at discharge. This is only looking at, all 3 of these columns are only looking at while the resident is in your facility. So day 1, 2, or 3, if we have documented that they had IV chemotherapy, maybe they went out to the oncologist, had that done in the first 3 days of the stay, we would code chemotherapy on admission while a resident, and then IV on admission. So this sub element will also apply for the oral if it's administered through a feeding tube or PEG tube enterally. So oral would also include that tube feeding. And then other, if that was given in a way other than intravenous or oral, intramuscular, intraventricular, intrathecal, intraperitoneal, or topical routes. And it doesn't matter where. So whether it was given in the facility, whether it was given on the oncologist, what we're looking at is, were they a resident of your facility first 3 days of the Medicare stay, last 3 days of the Medicare stay, or that 14-day look back for column B. We're not looking at that column B, only the chemotherapy, not the subcategories. Radiation does not have any subcategories, so that would be looked at on admission while a resident at discharge. And then we have respiratory treatments, oxygen therapy, looking at on admission while a resident at discharge, but our subcategories only on the SNF PPS stay, on admission, at discharge. Continuous, so this is looking at oxygen therapy continuously delivered for 14 hours or more per day. Intermittent would be not delivered continuously for at least 14 hours a day. And then high concentration is looking at high concentration delivery that exceeds the FiO2 of 40%. It can include either high or low flow systems, and it may include ventilator or trach masks if the FiO2 exceeds 40%. Also, O2 conserving nasal cannula systems with reservoirs if it's delivering that FiO2 of greater than 40%. If there is a question as to whether this is high concentration or not, you need to contact your physician or physician extender to see if it meets that criteria and make sure that the documentation is in place in the medical record to support that. And again, those subcategories only looking at the SNF PPS stay. Suctioning, we're looking at the subcategories of scheduled, meaning we have a scheduled time frame of when the suctioning occurred. And this is also looking at as needed. So we're looking at just as needed. And this is looking not at oral. So suctioning is nasopharyngeal, pharyngeal, tracheal, not oral. Respiratory treatments, tracheostomy care, invasive mechanical ventilator, non-invasive mechanical ventilator. We do have a couple of new subcategories under non-invasive mechanical ventilator where we can break it down between BiPAP and CPAP. One interesting note that was added under tracheostomy care, although there's no subcategories, there was a new note, and this was another thing that CMS had mentioned but didn't have anywhere documented, that tracheostomy care also includes the care of a laryngectomy tube. So if you have a resident with a laryngectomy, that counts as tracheostomy care if you're doing tube care for that laryngectomy, even though they're clinically different things. CMS has added that to the tracheostomy care category. IV medications is under the other category, so that is on admission while a resident at discharge. And then we have the subcategories just for the SNF PPS stay, looking to determine vasoactive medications, antibiotics, anticoagulant, or other. So if any of those were vasoactive medications, antibiotics, or anticoagulants, you will code that if it was delivered in-house, out of the building, but while a resident on admission, meaning the first 3 days of the stay, if they went out to the ER and had an IV antibiotic delivered in the first 3 days of the stay, even though it happened in the ER, we're still going to code it if it happened in those first 3 days of the stay or the last 3 days of the stay. When we're looking at anticoagulant, we do not include subcutaneous administration of anticoagulant medications. That does not count, nor does just a flush count. And then any other medication that is not a vasoactive antibiotic or anticoagulant, so for example, morphine or a diuretic, that would be coded under other. But again, just for the SNF PPS stay. Transfusions does not have any subcategories. Dialysis, we do have the subcategories of hemodialysis or peritoneal. Again, regardless of the location, if it was delivered while the resident was a resident of the facility in the first 3 days of that Medicare stay, would be coded under on admission. And then at discharge, the last 3 days of that Medicare stay. Hospice care, no subcategories. Isolation or quarantine for active infectious disease, no subcategories. And also no clarification. We were hoping maybe with all of the stuff that's happened over the past 3 years with COVID and isolation and all that fun stuff, that maybe they do something with that to provide a little additional guidance or something associated with isolation or quarantine. They did not. They added a couple of words in the title. Quarantine for active infectious disease does not include standard body fluid precautions. That was about the only change they added. Nothing else. The criteria for isolation has not changed with the updated manual. And then we have a new item altogether. 0011001 is IV access. So if the resident has access which refers to a catheter inserted into a vein for a variety of clinical reasons, including long-term medication administration, large volumes of blood or fluid, frequent access for blood samples, intravenous fluid administration, TPN, or in some instances, the measurement of central venous pressure. If there is an IV catheter inserted into the resident, we are going to capture that. Then for on admission and at discharge, is it peripheral, meaning it was placed in a peripheral vein and remains that way? Midline, if the midline access was in the anticube and it doesn't reach all the way to the central vein, or central, where the IV access was centrally located, even if it was peripherally inserted. So that the PICC line would be a central tunneled line, or port, those would be central. We also got some clarification that any other access, so if it was a hemodialysis, if there was IV access in the facility while they were a resident of your facility in the first 3 days, if there was access to that, anytime there's IV access, we need to look at that and capture. And then we have some more Section O updates, including the removal of the physician examination and physician orders. Those are removed from the full federal item set and manual. They are still on the OSA for the states that are using that optional state assessment. So I have good 15 minutes for your questions, and I'm sure you've got some. We can hit any of those other areas, certainly, that we did not cover, and hopefully I will have an answer for you. So do we have any questions? Or did I just shock everybody into silence? There's that too. I'm not seeing anything. I do see a request in the chat to post the YouTube website. So let me go back in those slides to put that YouTube site back on the screen for somebody who is looking for that. My recommendation is to take advantage of any and all training that is available, whether it be CMS, whether it be an association. All right, I see a question in the chat. Is a supplement for weight loss? Oh, I just lost it because I got more questions coming in. Let me make this bigger. Is a supplement for weight loss considered a therapeutic diet? So if we are trying to alter something, weight gain, adding protein, adding something, and it's related to micro or macronutrients for nutritional purposes, yes, that would be a therapeutic diet. Will there be a recording and slides? I do believe that Mountain Pacific Quality Health is doing a recording, and the slides will be sent off with that recording.
That is correct. Thanks, Jennifer.
Great. Let's see. I don't know if any other questions have come into you all. The chat is eerily quiet. I think I've scared everyone away. Well, we'll give you a moment to think about, and certainly if you have any questions, I'm going to put my email in the chat. And please don't be shy. Feel free to use it. I very much enjoy fielding questions. And a lot of times when we get questions, it's helpful for us because we're not in the field. So it helps for us to hear that information from the field. Are food allergies considered a therapeutic diet? Yes, if we are doing a diet to avoid those food allergies, peanut-free, gluten-free, in my daughter's case, raspberry-free, yes, that would be a therapeutic diet. So I guess my daughter's on a therapeutic diet, raspberry-free. Never thought of it that way, but absolutely it is. I do recommend going through the SNF QRP frequently asked questions from the training this past summer. That had a lot of helpful information and a lot of questions that other people, including a PACN, had posed. We do have, several items on a PACN as well, podcasts and some webinars related to questions that had come in and questions and answers that we had received from CMS. I think that was part of the reason why we had some delay in getting the final manual out, is because we kept asking questions, and I really needed to research that and figure that out before they could put out that final manual. I'm not seeing any more questions. Well, I hope this was helpful for everyone. Like I said, I'm more than happy to answer your questions. J LaBay at aapacn.org, and hopefully I can guide you in the right direction with any questions that may come up. But I do recommend one of the things that was of a concern, which wasn't part of today's presentation, was if you're doing a Medicare Advantage plan that requires a PDPM score. One of the items CMS clarified in the final manual was that we cannot code that as a PPS 5-day assessment to get that PDPM score. And basically, the reason why they've gotten real harsh with this and cracking down is there's still a lot of facilities that were completing an admission assessment combined with a 5-day assessment to get that PDPM score, admission to meet the OBRA requirement, and then the PDPM PPS assessment to meet the HIPS code requirement for the Medicare Advantage plan. We are not allowed to submit to IKEYS a PPS assessment unless it is truly a Medicare resident. And a lot of facilities were still doing that. So to really crack down to prevent that, in the manual, it says we cannot code a Medicare assessment in A0310B if they are not a Medicare Part A resident. And basically in the SNF Open Door forum, they basically said, well, your software should be able to create a unique assessment for that type of situation, one that will not be submitted to the federal government. So if you're utilizing a software that allows you to select a type of assessment that is not a CMS required assessment. Some softwares have a checkbox or something that you click to say this is not a CMS required assessment, then you're okay. You can continue to do what you've been doing and just make sure that that does not get submitted. But if you do not, and then that mistakenly gets submitted, that's going to be a problem. CMS is going to have issue with that. You will not have followed the RAI users manual, because if it's not a CMS required assessment, we shouldn't be submitting it. So they really are trying to separate between what's going on in federal versus what the individual private insurance companies are asking. They can't make the managed care plans do anything, or they don't tell them they have to do anything. So just be very mindful of that when you are completing your assessments for Medicare Advantage plans. Pretty quiet in the chat still. So hopefully we got enough information for you. And if you have any more questions, feel free to reach out to any of us and we'll make sure to get your questions answered.
Yes, and before you guys hop off, we do have a link in the chat for an evaluation if you guys wouldn't mind just going through that before you hop off. If you guys have questions, again, feel free to email Jennifer, myself, or Tim even. And we would like to thank Jennifer again for her time today, and also for Tim and his work and the Wyoming Department of Health for helping us get this training set up. So we are all prepared for the October 1st rollout. So there was a question about more webinars available. Mountain Pacific has the previous webinars that Jennifer has done available, as well as the slides. And then this one will be available on there as well. At this moment in time, we do not have any future webinars planned, but I'm sure maybe somewhere down the road we will get that set up.
I think they said probably more questions after we use the new form. Yeah, probably.
Yes.
So maybe we'll have to schedule something after that. Well, thank you so much for having me. And
Yes, thank you again, Jennifer.